Hey guys, welcome back to St3 Hacks, and today we're going to continue our lower limb series and talk about tibial shaft fractures. Let's start with the pathoanatomy. There are deforming forces that act on the tibial shaft, and these are mainly of the quadriceps, which act via the patellar tendon and tends to pull the proximal fragment into extension. There's the gastrocnemius, which originates from the posterior femoral condyles and flexes the distal fragment posteriorly. And then there's the pes anserinus, which contributes to varus deformity due to its medial pull. And the result of this is often an apex anterior angulation of the two fragments, varus malalignment, and potential shortening. Moving on to the radiology, you normally want plain radiographs with AP and lateral of the tibia, including the knee and ankle. This is a diaphyseal fracture and is often angulated and shortened, and that's what you want to really talk about. Key points for the St3 level is that you always want to obtain ipsilateral knee and ankle radiographs to exclude intra-articular extension. And if there is any concern for intra-articular extension, you should get a CT scan to delineate the articular involvement and plan for fixation. Key concerns in this case is that you treat it as a polytrauma patient, as this is normally quite high energy injuries with ATLS principles ensuring hemodynamic stability, open fracture assessment, compartment syndrome risk, and stratifying the associated ligamentous or vascular injury. Proximal tibial fractures carry a high risk of malalignment, compartment syndrome, and soft tissue compromise. The guidelines for this obviously are your BOSE guidelines, but in terms of management, one of the papers that I did note down for my notes was the Vanderpool et al. 2024 paper in the Journal of Orthopedic Trauma, which suggested that suprapatellar nailing may result in improved alignment and functional outcomes as compared to infrapatellar techniques in proximal tibial fractures. And there was reduced malalignment rates in this fracture pattern that were observed. Moving on to your triple assessment, you want to ensure a detailed history, including mechanism of injury, ample history, inquire about any opening injury, any red flags for compartment syndrome in their presentation, social factors including diabetes, smoking status, occupation, functional baseline that influence healing and rehabilitation planning for the case. In terms of your examination, you want to look, feel, and move approach. Ensure that you've thoroughly inspected the limb for open wounds, compartment assessment with pain out of proportion, pain on passive stretch, a detailed neurovascular assessment that's been documented, and maybe assess the knee ligamentous structures, but I doubt this will be possible in the acute setting as the patient will be in a lot of pain. Investigations, as we said, include an AP and lateral of the tibia, including the joints above and below, CT scan if there's worry for intra-articular extension, and some of the patients may have had a trauma CT anyway, if they've had a trauma call out, if it's a high energy mechanism. In terms of your bloods, you want your FBC, UNEs, cross-matching group and saves ready. And then let's move on to management. So in management, you've got your non-operative options for which are indicated for patients with minimally displaced fractures, significant comorbidity and low functional demand. And the management here would be an above knee cast in 20 to 30 degrees of flexion with VT prophylaxis as per NICE guidelines. And at 4 weeks, you normally convert this to a functional brace. And the main essence here is that you follow these patients up with close radiographic follow-up in outpatient clinic. Now, this is far less common in younger high-demand patients, and the aims of fixation are to correct length, alignment, and rotation, LAR. And you restore the mechanical axis, you provide relative stability to allow secondary bone healing, as normally these are diaphyseal fractures, and this should hopefully allow you to enable early mobilization and weight bearing where appropriate. Of note, malalignment of more than 5 degrees in any plane is associated with worse outcomes and should be avoided. Operatively, you've got X-fix for 1 to 3 weeks if there's damage control orthopedics in play, if there's polytrauma, severe soft tissue injury, or physiological instability, and then this can be followed up by definitive fixation, which normally is the gold standard with intramedullary nailing, and which requires enough proximal bone to accept the locking screws. You can also have an ORIF with percutaneous locking plates for extremely proximal fractures, but in this case, then the patients can't really weight bear, and that obviously prolongs their recovery pathway. Moving on to consent and complications, you have your general surgical risks, including pain, infection, bleeding, neurovascular damage, stiffness, malunion, non-union, risk of thromboembolisms, and then you've got your specific risks here, which is of 30% of patients complain of anterior knee pain, and they should be made aware about this, which is especially common after tibial nailing. And with that, we come to the end of the tibial shaft fracture series. If there's anything you think I've missed, please let me know in the comments and reach out to me on any of my socials. And I wish you luck in your revision, and we hope to cover more of the cases in the coming days. Thank you.